Okay, it
So
has.
shall I begin the introduction? Yes, sir.
It has started transferring, right? So please carry
Right, sir.
on. Right.
Yes, sir. Shall I begin the introduction part?
Yes, please. Please.
Right. So a very good morning to all of you, and we welcome you all to yet another YNF session, and this time it is on the critical care EEG. So before we introduce our main speaker, let me set the stage for how and why we planned this session. The session was suggested by Gagandeep sir, and the way we look at it, or the YNF looks at it, is like this. There are two types of trainees who are coming out of our training. Some of us have been trained in high-end epilepsy centers. We have done critical care EEG and we are passionate about it. And then we are released into a system where we are unable to implement what we have learned. And it can be a little overwhelming that we have really learned the standard of care and we are unable to do it. And there is another set of us, DM trainees, who have passed out of relatively resource limited settings. We have been taught, but we haven't seen the practicalities of critical care EEG monitoring. And then we end up in corporate practice or in the private world, and we feel a little bit of deficit in the practical learning of critical care EEG. So we both want to adopt critical care EEG in our everyday practice and do current standard of care. So teach us and give his clinical experience is a doyen in epilepsy care. To say that he is the professor and head of Department of Neurology at Dayanand Medical College, Ludhiana, is probably a very subdued introduction. Sir is a visionary and he is a leader. If I've had the opportunity to work or I'm working with him, and you see what it means to have someone who works with a vision. So with that introduction, I invite Gagandeep Singh sir to our platform and I thank him for giving us his Sunday time to this YNF session. Thank you, sir. And I introduce Dr. Saraswati, who is the chair of YNS, to Gagandeep sir. And Saraswati, please introduce the panelists.
Thank you, Jyotsna. I think we have this platform where we're both celebrating the excellence and experience in neurology. So it's great to have senior moderators and junior moderators here. And today we have with us Dr. Ajay Asrana, who was the previous convener of this forum along with Dr. Divya. So welcome you, sir. Dr. Ajay is additional professor of neurology at NIMHANS, and he's an epilepsy expert. And we already see an aura around him whenever he's around us in the campus. So we wish to have beautiful talk by you, and hopefully we'll learn a lot of points from you today, sir. We have with us Dr. Niharika Sriram. I must say Niharika is one who is really driven by passion and commitment. So all these young neurologists really drive this field. So Dr. Niharika is now, after her DM in neurology, she's actually pursuing further epilepsy at Cleveland Clinic. So she's an epilepsy fellow now. We welcome Niharika, and through this multinational viewpoints which we generate today, I think that will drive all our young neurologists to take interest in epilepsy further. We have with us Dr. Harish Jaikumar, who is the clinical director of JK Comprehensive Epilepsy Center from Madurai. So welcome, Harish. And Dr. Prabjot Kaur, who is a clinical fellow at the Hospital for Sick Children, Toronto. So all these young kids who were once doing DM and now they are climbing the ladder at a pace which is really very delightful for us to see. So welcome you all. And please over to Jyotsna to have an introductory part for this session.
Right. Asmita ji, are we ready?
Okay, ma'am, just in 5 minutes, it just received.
Right. So, sir, would you want to make a few introductory remarks before the... You're muted, sir.
Yes. So thank you so much, Dr. Jyotsna, and thank you so much, all the great panelists. Ajay is a good friend. I'm meeting Saraswati and Niharika and Prabjot for the first time. And also, I can see so much of enthusiasm. So many people have joined in, right? And that itself is a great kick to me to take this further. Just two things actually. Uh, Two issues. I've been having a cold, but hopefully, so kindly bear with me if I start coughing in between. But I have a glass of water here, right? And the second thing is my system is not sharing. Allowing me to share my slides, right? But no problems. I've just transferred my slide set to Asmita, so hopefully she has it ready. And as soon as that is ready, but yes, fine, good. I can see these slides, right? Can everyone see these slides?
Yes, sir.
Right, fantastic. I think my computer was having an absence seizure and it went on and on. So it was an absence status epilepticus, right? And we are here to discuss critical care EEG as Dr. Jyotsna and the entire team very nicely introduced the subject. It's actually a very vast topic. And I can say I'll just be touching on some selected aspects of convulsive as well as non-convulsive status epilepticus. I will have to tell you too. So much of what I talk is premised on this paper, which is actually a landmark paper. It's a benchmark. This is where your critical care EEG begins, right? Anyone who would like to do critical care EEG, if he has to read something, he doesn't have to read too much, right? It's like Jyotsna said. There are two types of young neurologists here in this forum. So for both the types, I think you want to begin with critical care EEG. You don't have to read too much. You know, there are no huge textbooks on critical care EEG. Or there are a couple of books now available on critical care EEG, and they're very good books. But if you read this one paper, it's about 29 pages. It would really suffice. You would get to know the hang of what or the theoretical basis of critical. Rest of it is all practical and it means putting a lot of time. Next slide, please. Thank you. So I thought I would build it into a case which we managed some time back, about a few months ago. This particular patient was admitted, um, and would build in some of the concepts, and we would discuss some of the concepts in as we go along the case. I think there are a couple of yes, there are a couple of more cases. So a total of three cases, and this one is a 34-year-old previously healthy male, right? It was new onset, started with fever, altered sensorium for 4 days, and during this period, he had multiple generalized tonic-clonic seizures over a couple of days in an outside hospital, right? Before being referred to our hospital. The outside hospital MRI brain was normal, and he was treated with lorazepam, levetiracetam, lacosamide, phenobarbital. Midazolam infusion was started. Patient was obviously intubated on a ventilator as he was transferred. And when he arrived in our emergency, there were no active convulsions at that point of time. His vitals were probably stable, and there were no focal neurological deficits, right? Next slide, please. Uh, However, um, as he was in the emergency department, he had a generalized tonic-clonic seizure, and the resident ordered an additional 10 milligrams of midazolam, which terminated the seizure, right? The nurse collected blood. That's standard status epilepticus management. I would not go into that. But then coming to this question, it's should we start doing a EEG out here? This patient has already been investigated in an outside hospital. I think I forgot to mention a lumbar puncture was done as well, and a lot of samples were sent, including autoimmune markers and paraneoplastic markers and so on so forth, right? So the question is, should we be doing an EEG exam at this stage? And and if at all, how would it really be helpful in this stage? Next slide, please. Uh, just a point, and I think most of you would understand this very well and already know this. Most patients, once they have a generalized tonic-clonic seizure, recover consciousness between 10 and 15 minutes, 5 and 15 minutes, right? But under certain circumstances, the recovery from the unconscious state can be, or the comatose state can be pretty prolonged, right? And particularly if the patient has had a very prolonged seizure or a status epilepticus, many recurrent seizures can take some time. Um, if there is some underlying acute structural condition, traumatic brain injury, stroke, or encephalitis, which might actually be responsible for the impaired consciousness, right? Um, but also keep in mind that status epilepticus can be followed by non-convulsive status epilepticus, and the frequency is almost like about 50%, right? 50% cases of convulsive status epilepticus eventually stop having the tonic-clonic convulsions, and the reason for that is there is fatigue and exhaustion in the descending reticulospinal pathways, and therefore the convulsive movements stop. And there are some very good papers regarding this, right? And this itself is an indication. In our hospital, we very frequently we are very upbeat about doing immediate EEGs or urgent EEGs after an acute seizure when the patient presents to the emergency department. And we proceed as follows. Next slide, please. Asmita, thank you. Right. Um, so we do a 1 hour EEG. And this slide is about would you do a continuous EEG, and what are the limitations of the half or 1 hour EEG that is usually done, and what are the advantages of a continuous EEG? So the half an hour EEG, it's the difference between a still picture or a snap and a video, right? Right. It said picture tells us what we can understand in 1,000 words. Video is probably 1,000,000 words, right? You really can't. You administer some treatment, and what happens to the human brain or the functioning of the human brain at that point of time, that really needs you need to have a continuous long-term EEG in order to capture that, right? We are also very upbeat about doing continuous EEG, but the first thing that we do is to read that first 1 hour of EEG very quickly, right? It should be read ideally in real time. I completely understand as residents and busy doctors, consultants as well. It's really difficult to stand by the EEG and continuously interpret it. But as soon as possible, next slide, please. Uh, yeah, and um, this is when would you really do a long-term EEG, right? Or when would you do EEG? And we have some criteria for that. The ACNS says if the patient does not recover consciousness after a convulsive seizure, the European Society for whatever critical care medicine, right? If the patient does not, their guideline is if the patient does not recover consciousness within 60 minutes of a seizure. But what we basically do is we try to hook the patient onto the EEG as early as possible. And at the end of that 1 hour, we review that EEG, try to estimate the 2 help to be score, which is very simple, and I'll come to that. And then decide whether a continuous EEG really is required or not. Right? The patient is really in status, right? And you have put the patient on EEG. You are very likely to record at least an electrographic seizure within the first 1 hour. And most of the electrographic seizures would, 80% would occur within the first 1 day. Next slide, please. Right. And so what is this help to be to score? I think many of you do this. This 1 hour EEG, these are the things that we look for. We look for birds, and I'll come and show a good example of birds, or lateralized rhythmic delta activity. The patient usually has had a seizure, or the patient might have a seizure during that 1 hour recording. And you give 1 point for that. And then there might be lateralized slowing, which is not rhythmic and which is not periodic, is almost continuous, more than 10 seconds. You could have generalized periodic discharges, sporadic epileptiform discharges, and then if the frequency for any of the periodic patterns is more than 2 Hz. So total points is 7, right? And birds are probably the most epileptogenic condition, so they get 2 points in this particular scoring system, right? And if someone has a score of 1, right? Uh, okay. Prabjot, you want to ask a question? You've raised your hands. I'm quite okay. Hello.
So I think it's by mistake, sir. Sorry.
Okay, no problems. No. So someone has a score of 1. That means there is a 10% chance that you would record seizures in the next 24 hours, electrographic seizures, right? However, as you see, the score is increasing. With a score of 4, it is almost 70 to 80% chance that you are going to record seizures, right? Now, what is a score above which or at which you will initiate continuous EEG recording? Now that we don't have any guidelines in our hospital, we use a threshold of 10%. So if we think someone has a score of 1 or more, the risk of the chances of us recording a seizure on continuous EEG in the next 24 hours is 10%. And we believe that justifies us doing a continuous EEG. But this might vary, and we do not have a firm guideline regarding this, right? Okay, next slide, please. So if you look at this, you can see some rhythmic activity, which is there mainly on the left side, the blue electrodes. It lasts for about 2 to 3 seconds, right? It's pretty rhythmic, although there is some evolution in frequency. The beginning of it in the center of the EEG panel, the rhythm is a little faster, and then it becomes a little slower. So there may be some evolution, if you want to say. It's basically more than 4 Hz. So any rhythm like this, lasting up to 10 seconds, um, and the frequency is more than 4 Hz, this would be classified as birds, right? And this, in this instance, seems to be coming from the left side. And this is highly, you see in the 2 help to be score, it's accorded a score of 2. It's highly epileptogenic, roughly about 70%. If you record this on a continuous EEG, you are likely to find electrographic seizures in 70 to 80% cases, right? Next slide, please. Okay, so coming back to that paper which I had shown by Lawrence Hirsch, right? How do you go about describing it? It's like describing any EEG pattern. You have a transient. How do you describe the transient? You describe the distribution, the pattern, and then there are some. This is from the ACNS. So the main terms are the distribution. Is it lateralized, generalized? Is it bilateral independent? Or there might be two independent discharges coming on one side only. That would be unilateral independent, right? And then they have to follow a pattern. Either they are periodic discharges, there's rhythmic, slow, they're birds, or it is a spike wave discharge. And then you need to describe, and they call it as modifiers. It's just like how you describe a transient on an EEG. So the prevalence, are they continuous more than 90%? Are they abundant? Are they frequent, infrequent, rare? 1 per hour, I think, should be rare, right? How many phases are there? Is there any stimulus sensitivity? That's extremely important. So these are some of the modifiers. I'll come to this plus thing. If there is a plus to any of these patterns, that increases the level of epileptogenicity, and I'll show some examples of that, right? Next slide. So we saw some birds, right? And this is a lateralized rhythmic delta activity. Again, on the left side, you can see there is it suddenly begins and probably ends on the next page, right? So this is LRDA again. So the difference from birds is that birds are more than 4 hertz. This is less than 4 hertz. LRDA typically, to call it LRDA according to the ACNS criteria, should be less than 10 seconds, right? Next slide. And this is, well, in comparison to birds, it is slightly less epileptogenic. So if you put birds at 70% chance of electrographic seizure, this you would put as 40 to 50%. So now coming back to the patient was shifted to the ICU. Continuous EEG recording was done. In the beginning, there were no electrographic seizures, and however, Asmita. Right. Okay, fantastic. Right. This is what we got. This is on stimulus, right? A stimulus was given. You can see it, the green um, triangle right in the beginning of the EEG on the top is where the stimulus was given. And this was the kind of discharge that was recorded, right? Uh, Next slide. So what is this, right? So this was, well, this is Ceripids, right? Stimulus-induced rhythmic periodic ictal appearing discharges. So, last for some time, say about 3 to 5 seconds. There is no evolution, right? There is no clinical concomitant with them. So it's really not a seizure. I mean, it's not an ictal rhythm. Usually is found in advanced, pretty late in the course in status epilepticus, right? Not in the early stages of status epilepticus, and just means increased hyperexcitability of the cortex. And no need to treat this, no need to escalate your anesthetic agent at this point of time, right? Next slide. So yes, okay, so I spoke of lateralized periodic discharges, but sometimes they have plus, right? So there is a discharge, as you can see on the left side, uh, and on the top of it there are some faster rhythms, right? Do you all agree? There is actually a lot. It's really not um, a spike or a sharp wave. It's probably a slow wave with some faster rhythms on the top. When there are faster rhythms associated with periodic discharges, they are called as LPD plus, right? And LPD plus means, this is probably another example. An LPD plus um, connote a higher epileptogenic potential, a higher chance of recording seizures in comparison to LPDs alone, right? Likewise, LRDA can be associated with some plus features, and any of the the patterns can be associated with plus features. Next slide. Right. So some of these things are pretty straightforward, right? But some of these things might not be discharges, which you can see in the background. Right frontal region, mainly FP2PZ, right? We'll call them LPDs, right? And we know, and there is this huge controversy whether lateralized periodic discharges are ictal or interictal phenomena. The consensus is, and I remember Niharika is from Cleveland, and I remember Dr. Hans Luders once many years ago, whilst at the Cleveland Clinic, and this is during those introductory courses that you have for EEG right at the beginning of your fellowship, Niharika. And I asked him, he showed a EEG of lateralized periodic discharges. This is about 25 years, 24 years ago, right? And he says these are lateralized periods. So I said, would you treat this patient? He said, I will just give this patient some Dilantin and nothing else. This is what Dr. Luders said at that time, implying that, well, these patients are at increased risk of seizures, but we don't have to treat them aggressively, right? But if you look at the EEG, and then next slide. Can you play the video? Yes, fantastic. And you look carefully, there are some twitching movements of the fingers, right? So is this ictal or interictal, right? If there is a clinical, sometimes the ictal manifestations can be really, really subtle, right? Absolutely subtle. And if there are some subtle, however subtle the clinical manifestations might be, then it is an electroclinical seizure and it's not purely an electrographic seizure, right? So always look for these subtle movements, right? So this emphasizes, I mean, if this patient had no such subtle movements which were seen, we would have said, okay, fine, these are just LPDs and nothing, right? We don't have to aggressively treat. But if there are some subtle movements on the contralateral hand, right, then it becomes a different thing, right? It clearly implies. So there is, what you realize that there is a spectrum or there is a continuum, and this is where we come to next slide. Right. Or you have something like this, right? Um, this is a patient who has LRDA, right? On the left side, there is lateralized rhythmic delta activity, but it goes on and on for a long period of time, right? So not just for less than 10 seconds, as is the ACNS clinic, the criteria or definition for the LRDA. Next slide. So this is where we realize that this is all a continuum, right? From what is interictal to what is ictal, right? And in this spectrum, well, the ACNS document usually, most of all, it says that when the discharges are more than 10 seconds, whether it is LRDA or whatever, then that comes in the ictal interictal continuum. But then there is a whole lot of controversy. When you see lots of triphasic waves, could that be ictal, right? So there is an entire spectrum, and this slide depicts the continuity between the interictal and the ictal state. And of all the interictal phenomena, perhaps the highest risk for seizures in the next 24 hours are with LPDs, followed by LRDA, followed by generalized periodic discharges, and I think the least is, less than 10% is generalized rhythmic delta activity. That probably has the least propensity for seizures. Next slide. So again, then coming back to the patient, we gave him lots of midazolam, but then he continued to have seizures, and because he had seizures, he was substituted with propofol, and the dose was gradually increased, right? So again, we come to a question of how does EEG help in the management of status epilepticus? Next slide. Yeah. So these are some of the kind of seizures that he had, right? Starting on the right side, you can see he was at different time periods. I think he had seizures, some coming from the right side, some coming from the left side. This is one of the seizures that began the way it began. You can see beginning from the right side, frontotemporal region, right? Next slide, please. Right. So many years ago, and this was in 1990, and David Freeman, he used to work in, I actually had the opportunity to meet him. He used to work in Barrow Neurological Institute in Phoenix, Arizona, right at that point of time. And he first did it in animal experiments, but then he demonstrated these sequential stages, electroencephalographic stages of generalized status epilepticus, right? And he postulated that a patient, as he goes into refractory status epilepticus, goes through a stage once you have discrete seizures where you have seizures, and after that the EEG, there might be some initial slowing, excuse me, some background slow after the seizure, but then eventually the background also becomes what it was before. So they are discrete seizures, and they're going on to merging seizures with waxing and waning activity, continuous ictal activity, eventually to generalized periodic discharges, and lastly to electrocerebral silence. And the prognosis in terms of recovery, prognosis in terms of control with your anesthetic agents depends on what stage um, are we at, or what stage is your patient at. Now, the problem with this is, why did this classification or staging not become very popular? Is that this staging is modified by treatment, right? You give anesthetic treatment and you induce burst suppression. So you don't see all these stages as you would see. But there are some reports in literature where you have a patient, this one of the case reports, the patient was refused treatment, right? The family said, no, we are not going to give any treatment. So they recorded all the 5 stages of status epilepticus in that patient, right? Next slide. Yeah, so this is, so you can see the seizure beginning somewhere in the middle of the EEG page. Next slide. And then it stops very soon. There's a little bit of suppression after that, but then there is some more epileptiform activity, but then the EEG rhythm gets restored, right? So these are discrete seizures, right? Next slide. However, in this particular EEG graph, you can see the seizure starting from the right side. Next page. It's almost like waxing and waning. So you have merging seizures, and it would go on for minutes and minutes. This, I mean, I can't show you all the pages, right? But just goes on and on. Please, next slide, Asmita. Yeah, okay. So you can actually discern these stages. But then coming on to this larger question is, how does EEG really help in the management of status epilepticus? How does it guide when to start treatment, how to escalate the treatment, right? The anesthetic agent, up, what is our therapeutic endpoint, right? And then when we start de-escalating treatment, at what pace do we de-escalate, right? How do we reduce the anesthetic treatment, and when do we stop? And then once we stop, there are always, as you would understand, chances of rebound seizures, right? And to detect those rebound seizures, again, you need to have the patient on continuous EEG monitoring, right? So these are, I mean, the therapeutic endpoint itself is really controversial, right? Some people would say, okay, fine, it's just enough to stop the seizures from happening, and that should be fine, right? But some people go for burst suppression, and there is a ACNS definition for burst suppression. And quite often, burst suppression, you might think that the burst suppression is desirable, but it does not happen when you really want it to happen. And it happens when you don't want it to happen, right? And then please try to understand, we should not, and in every instance, try to chase a burst suppression or try to keep on increasing the anesthetic dose to achieve burst suppression. You need to keep in mind that there are profound complications of anesthetic treatment, and these complications can be life-threatening, paralytic ileus, pneumonias, and so on and so forth, hypertension, cardiac dysfunction. So that's the flip side of it, right? Extreme is EEG suppression. Some people, and particularly there are a number of publications from Germany, absolutely flat EEG, right? So there is this huge controversy everyone pursues. We think that it is good to have cessation of seizures. Some cases, yes, burst suppression does well. Certainly not the EEG suppression, right? The seizures should stop, the status should stop. There should be no breakthrough seizures. There should be no rebound seizures after stopping, and there should be no complications, right? Okay. Next slide. Jyotsna, let me know when I have to stop, right? So what happened next, right? Go to the next slide. Just quickly. Next
Please
slide.
continue, sir, until the presentation. We have time.
Okay. So, yeah, so this patient went through all these stages, right? Next slide, right? And these are some examples of burst suppression, right? This is pretty clear, right? Another example of burst suppression, right? Next slide. And now you see this is another example of burst suppression, right? But you see this is slightly different from the previous two EEGs, right? You have very highly epileptogenic discharges within the bursts, right? As opposed to the previous. So the first two, I think, and this is my view, that you really need to differentiate between these two forms of burst suppression. The first form is a benign form, right? These are patients who are probably at lesser risk of rebound seizures once your anesthetic drugs stop, right? And the ones like this, they are very highly likely to have both breakthrough seizures and rebound seizures. I don't have data to prove this, but this is my gut feeling. And these are not good looking bursts, right? These are epileptogenic bursts, right? Okay, next. And then this patient eventually, despite all treatments, if I remember correctly, eventually ended up giving him thiopental as well, very high doses, all kinds of treatments, steroids, intravenous immunoglobulins, and he just did not improve. And then he started having these generalized periodic discharges, right? Whatever we did, this is what in the last, I think 1 day or so, right? Next slide. And these generalized periodic discharges became more and more infrequent. As you can see, the suppression periods went on increasing, and the discharges becoming more sparse until eventually the patient died, right? So a sad ending, but even so, I think it's provided us with a wealth of information and understanding on how status epilepticus evolves. Next slide. Yeah, so I think this, please carry on, Asmita. Yeah, so these are some of, this is how, the EEG progressed. There were merging seizures, then continuous ictal activity. Then we started getting GPEDs, and the GPEDs started becoming rare and rare and rare and sparse. And eventually there was an electrocerebral silence, right? So this is, uh, these are the stages of status epilepticus. Next, please. Okay. We come to another case, and this is two short cases, right? And this patient actually presented to us in the outpatient department. The old patient of mine had actually come after 1 year of follow-up, right? Didn't follow up for nearly a year. 74-year-old woman, established diagnosis of Alzheimer's disease, and was on treatment with rivastigmine and memantine, right? She had a tonic-clonic seizure. The history was like this, the present illness. She had a generalized tonic-clonic seizure a week ago. And then the family said after the generalized tonic-clonic seizure, she's really not what she was before. She's really very drowsy, sad, uh, she's unresponsive. And so we naturally admitted her, and we uh, did all the blood tests and everything, uh, electrolyte, sodium, whatever, and everything was absolutely normal, right? But bloods came later, but something instinctively, and just because I think because she had a generalized tonic-clonic seizure a week ago, we shifted the patient right from the outpatient department to the EEG lab, right? Next slide. And this is in the EEG lab. If you can run the video. So eyes are open, and she's not unconscious or anything of that sort. But you all notice the myoclonic jerk that she had, right? And next slide. Right, and this is one of our residents who's with the patient, uh, giving some intravenous agent. Can we go on to the next slide and show the EEG? Next. Okay. Right. Any idea what was that? What was that place? Right. This is Salzburg, right? The Mirabelle Garden in Salzburg, right? Okay. And next slide. And we have the Salzburg criteria for non-convulsive status, right? Um, we'll come to this again. Next slide. This is what the EEG of this patient showed, and she had this jerk, and this probably represents the jerk, and this is what the EEG looked like. Next slide. So very epileptiform looking EEG with these repetitive triphasic waves does not strictly meet the Salzburg criteria, where you need to have discharges at the rate of 2.5 hertz. That means in a 10-second page, you need to have at least 25 discharges. But clearly, this is an highly epileptogenic EEG, and this patient was given a little bit of benzodiazepine, put on levetiracetam. Next slide. This is more of the EEG. I think we're trying to show that Some of the discharges disappeared after the benzodiazepine. Next slide. Some are still persisting. Next. Yeah, and this probably shows normalization after the benzo. Next. And this is the patient. Is there a video? Right. This is the patient a week after she had presented, right? She's pretty interactive, right? She's much more interactive than what she was. She's demented. Her MMSC was probably less than 10 or so, but she's pretty much more interactive than what she was, right? Next slide. Next, right. So the other thing that in our department, and this is over the last 4 or 5 months, right? There seems to be an epidemic, right? And this is one of our residents. His name is Varun, right? And he seems to be a great expert, in diagnosing non-convulsive status, right? And you can see he's trying to wake up this patient. He is pinching the patient, tapping, and the patient is absolutely non-responsive, right? Okay. And he knows that this is the kind of patient where I put in the EEG, put up the EEG, and I'm going to find something, right? He's very good at diagnosing this particular condition. Next slide. And this is what the EEG showed, right? So this almost meets Salzburg criteria. There are probably 25 discharges, very triphasic looking discharges, sharp waves throughout the entire EEG, right? Next slide. Next. I think it goes on and on. And at this point, he gave a little bit of benzodiazepine, just 2 milligrams of benzodiazepine. And then I think he loaded with the patient with levetiracetam, right? And the thing started clearing. It didn't clear immediately, right? It took a little while to clear, about half an hour or so, for the discharges to disappear, right? And a few days later, it was an absolutely quite a good looking EEG. Next slide, please. Yeah, this is probably a few days after, if I'm not wrong. Next slide. And this is the patient about 3 or 4 days after. Asking him to lift his hands, he's doing that pretty well, right? Okay. Next slide. So what is this group of patients, right? Virtually all of these patients come from the nephrology department, right? Next slide. Right? A number of them are on antibiotics. It's not just cefepime, right? The last patient which Varun told diagnosed was Zavicefta, right? That is ceftizidime, whatever you call it, right? Okay. Next slide. So they're all mild renal failure. The serum creatinine is about 2 to 3 to 4. They're older people, more than 65, altered mental status. Few of them might have few myoclonic jerks. And we have learned not to treat them very aggressively. 1 or 2 patients in the beginning we used to treat really aggressively, right? We just give them 2 milligrams of benzos, but we don't expect that neither the EEG would improve immediately, nor would the patient actually sit up. The response comes over a few hours to days, right? The effect of ending drug, right? So we have learned, and we have moved from aggressively management managing these patients to watchful expectancy, just give a little bit of benzodiazepines and carefully observe for slow improvement in these patients, right? Next slide. So that's it. When do we suspect these patients, right? And the most important thing is to withdraw the offending antibiotics, give a little bit of benzodiazepines, and the patient would slowly and gradually improve, right? He's not going to sit up immediately, the way it is mentioned in the Salzburg criteria. You give benzodiazepine, the patient sits up, right? No, that doesn't happen. It's always a slow process. Next slide. Uh, yeah, I think that's uh, next. Right. These are not my takeaways, right? My key takeaway is that it always pays to do a EEG in critically ill patients, and there are surprises. When we started diagnosing these non-convulsive status epilepticus, they came in loads. I mean they come in loads. Most of them, as I said, come from the nephrology intensive care unit, right? Our EEG technician said, well, we've been seeing these before, and we used to think these are all triphasic waves. They're not triphasic waves, they're non-convulsive status, but you don't have to manage them like convulsive status. You have to manage them uh, with a much lesser degree of urgency, more of expectancy, and things eventually turn out to be good. Thank you so much. I'm stopping here, right?
Thank you, sir, for that wonderful talk. I think the real implication of finding a, a discharge on the EEG was made really clear to us. So, do we begin the panel, sir?
As you said.
Yeah. So, the overall structure of this panel is we have four young neurologists sitting across different parts of the world, but all of them have had an exposure to the Indian setting. And now, with representing their respective workplace scenarios, they are going to share with us how they look at critical care EEG. Are they able to implement it in their workplace setting? And what are the pros and cons of their respective workplaces? So, to begin this, I start with Dr. Ajay. So, Dr. Ajay has been a through and through institute person, and he's trained in an institute, working in an institute in Imhans now. He was trained in Chitra, did his epilepsy fellowship in Chitra. Dr. Ajay, please share with us about your experience with critical care EEG monitoring in patients in Imhans.
At the outset, thank you for having me here, and thank you, sir, for that wonderful talk. It was enlightening on so many levels. So as Josna said, I work at NIMHANS, which is a sort of a tertiary referral center for neurology, neurosurgery, and psychiatry as well. So while we do get de novo patients, we also get a lot of referrals because the setup in the district hospitals may not be adequate to handle patients having status epilepticus. So that said, we do have enough number of epileptologists. We have 6 epileptologists in the department. We have 25 neurologists. We have all the ICU facilities, excellent neuroanesthesia support and radiology services as well. And we do have EEG and critical care EEG, but there are some things that we could improve upon. We don't do continuous EEG as much as we would have liked to, for a variety of reasons, including the availability of technicians around the clock. So it is really important to have EEG access. At least intermittent access is definitely necessary, without which you cannot manage any patient with status epilepticus. Just being guided by clinical seizures alone is not going to help. And ideally with a continuous EEG setting. Now, if you don't have a continuous EEG setting, the risks are that you may be either under-treating, where you're missing out on some electrographic seizures, or over-treating, where the anesthesia is more than what is necessary, and that can unnecessarily add to some morbidity. So we hope that in the future we are able to resolve this and have more continuous EEG services because it may be a formidable handicap. And if you're working in a setting where you're managing refractory status epilepticus, you should impress upon the management to try and get continuous EEG services. The other issue that we primarily face is the lack of ICU beds, which is because of we are overwhelmed all the time. We have all kinds of cases, strokes, traumatic brain injuries, in addition to status epilepticus, GBS. So all of them require ICU care. So there are also situations when patients who are in other private settings for management of refractory status epilepticus, it is financially very draining and it's a very chronic, it can go sometimes more than 2 weeks, 3 weeks. And then it's very financially draining every day in the ICU. And then they want to transfer the patient once they've exhausted their resources they want to come to demands, which is not always possible for us to offer because of the lack of ventilator. We have a dearth of beds. Now, I was recently reading an epilepsy paper which appeared in July, in the July edition, just the recent edition. So there they emphasize that having a network of hospitals which are earmarked as centers of excellence for super refractory status epilepticus and status epilepticus management. Like we have stroke-ready hospitals. We should also have some hospitals which are earmarked as centers of excellence, especially in the government settings, because even middle class people may not be able to afford this care for long if the status prolongs for more than 2 or 3 weeks. So this is these are my initial comments, and I hope I have given an overview of the challenges that we face.
Absolutely. I think working in Mysore and your center is very close to me. I totally understand that a patient who has drained resources 10 to 20 lakhs in a private setup and wants to go to NIMHANS and they don't get a bed. So the patient is lying outside in the corridor, sometimes in the ambulance, and then they are not able to enter the system, enter NIMHANS, is a story that I have often heard. So moving on, thank you, Ajay, for those wonderful comments. You have really highlighted the difficulties of an institute. I move on to Dr. Prabjot. Prabjot, you have seen AIMS, you did your DM there. You have seen a corporate setup, you worked there, and now you're at a place where ACNS is at your fingertips, right? So every other sentence here, like you're just quoting the criteria. So tell me what it is like across, in the North America and Canada, and what it is like now. How is it different, and what is your experience?
Thank you, Jyotsna. So at the outset, I think the major difference that I see here versus when I was training or when I was practicing is the difference in the resources. So I'm essentially, as from my perspective, in a resource setting, but as per the Canadian perspective, we are still in a resource limited setting. But when it comes to CEG, I think they're very generous with CEGs. We have 24/7 CEG monitoring for all the kids who need it. And we have at least one epilepsy fellow who is always on the CEG end, reading the CEG even at the back end. So for here we do CEGs for the pediatric indications, which are more or less similar to what we do for adults. So in addition to only status, we also have kids who are on neuromuscular blockade, who have high risk for seizures, who are after cardiac surgery, who undergo continuous EEG monitoring. And we also have a big chunk of neonatal kids who have abnormal CFM recordings or have abnormal movements suggestive of seizures or at high risk of seizures, who undergo CEG monitorings. So that is the kind of scenario here. And yes, here, any kid who requires a CEG gets a CEG. So that is, I think, a major difference that I see from when I was practicing back in India.
That's wonderful. So what do you mean to say is a patient who has undergone the heart surgery and is on a ventilator, prophylactically or rather proactively is put on the EEG irrespective of his a neurological concern?
Oh, no. In case they have, many of these kids will get a CFM first. So it is like a amplitude indicated EEG. And if some abnormalities are seen on that, or they see some abnormal movements, which might be concerning, then this child is put on a proper CEG. So in addition to obviously our kids who have encephalopathy, who are in status, or who like Sir presented, like Sir showed us a case, had a seizure, and then the encephalopathy is not getting better. Like those kids are the routine cases.
Yeah, I think that's the luxury of having a planned system. But then that is not the pragmatic real world. We take you back to a person who is in the thick of private practice, but a very passionate person, Dr. Harish. I would want you to share your experience. You were trained in Madras Medical College, it's a government setting, and then you came to Amrita to do your fellowship in epilepsy, and I have seen what epileptology fellowship in Amrita looks like. So now you've opened your own center and a private medical center in a tier 2 city. And what was it like, and do you implement critical care EEG in your setting? And what is it like to practice at your setting?
At the outset, I would like to thank Jyotsna for inviting me to be a part of this. When she called, I was really skeptical that I have to prepare so much because I'm in a private setting and I can't afford to spend so much time. But it was really an eye-opening for me to learn from Gagandeep sir once again. So thank you so much. And I would like to reiterate that I'm from a tier 2 city, Madurai, which doesn't have access to like very advanced setup. I always look up to Ajay, Dr. Prabjot, and all those people who are like very far away from what we do. So, but I'm very passionate about what I do. So, I'm a second generation neurologist. And my father had started the first digital video EEG in whole of South Tamil Nadu. But the problem is, I'm an epilepsy specialist. Without my armory, I won't be able to do some work. So whenever I go to a corporate hospital, they would very hesitant to start an epilepsy monitoring unit because he's already a neurologist. And what if I invest in this and then he might go back some? That's the problem that I face. That's a whole different problem. But I suggest I feel that was a big hurdle for me. So what we did was we invested in the epilepsy monitoring unit. It was a huge amount for us. But by the time we didn't think about the breaking even and all. But we started off and then we started off an epilepsy monitoring unit and then we started running and then we have done quite a few epilepsy surgeries and we're very proud of it. And the point is, we were able to find in a critical care, there is a huge lacunae in this area, at least. What we do is, to answer your question, do we do critical EEG as much as routine EEG? No, not so much. But we try and do as much as we can. I take the help of this help to score to be scored, and I usually think if there are birds, and we don't strictly follow that one score one. What I do is a score of 2 if it is birds, or if it is a lateralized periodic discharges. Even if it is 1, I can do a continuous monitoring. For all patients, we get an 1 hour EEG, and I can show you how we do it as a critical with the video EEG. Someone of the attendees had also asked, how are you able to differentiate the artifacts from the ventilator? I can show you how we used to do it, like a jugaad, how we used a small device which can help even use a video EEG in a critical care setting. I can show you that later on. But what we do is, if time permits, I can actually share the questions. What made a huge difference in our critical care monitoring is, is it okay if I share what I have?
Yeah, absolutely.
So, see, if you ask me, these are the kind of referrals that we get. See, this lady was treated in a psychiatry hospital for not going for a school for almost 2 months or so. Later on, she had some painful cramps or something. They thought she was faking. Later on, when she had all these, we rely on the videos so much. So this is how the presentation was, and then that's when they called me. Then they said, I asked them, "Oh no, this is a seizure. We'll have to look at what it is." By the time she was shifted to a hospital, this is another corporate hospital. This is how she was. So she had entirely reduced
Dr.
sensorium.
Harish, I don't
Open
think
We
I'm
are
mouth.
not
seeing your
able to
video.
see the video.
Oh, you're not
It's
able
not
to see the
playing.
video?
We are
Oh,
just
I'm sorry.
seeing them as small icons, and the real thing is not coming.
Oh, I'm sorry. One second. One second.
Yeah.
So are you Dr. Jayakumar's son, right?
Yes, sir. Yes, sir.
Give my regards to your dad.
Absolutely, sir. Absolutely, sir. Thank you, sir.
Okay.
I don't know if so. Are you able to see now? No.
No,
It's
no, sir. You have
it.
to share the video screen then. You have to click the video
Yeah.
and it open it on the second screen. So you have to share that screen, the entire video screen.
Okay. Let me.
Stop share. Stop share. Your video is already open.
Yeah.
Then stop. 1 second. I'll do that. Okay. Share again and just select that
Yeah.
Yeah.
Are you able to hear this? See this? Are you able to hear
It started. Yes, yes,
Yeah.
yes.
This is the presentation. This girl had presented to the psychiatry hospital because she was not going to school for a long time. And what happened was later on she developed some cramps or something, and then she was there. They assumed that she was trying not to go there. And then by the time she developed these kind of movements, they had called me saying that she's having some kind of movements. Please come and see. And then I asked them to shift her to the hospital, another hospital, and where this they are associated with another hospital. So are you able to see this?
Yet to display, Harish.
So this is
Yet
how
to
she presented to me.
Uh, your
So
screen
they
is
don't
not.
have access to a critical care EEG. I know this is a seizure. I know this is some kind of a seizure. So can you see this?
No, no, Harish, we are seeing your this thing. It stays started screen sharing now.
No, you're not able to see it.
Not yet. It says started screen sharing.
Are you able to see
You
it,
have
the video?
Not
no.
yet.
But I'm sharing. I'm sorry.
Okay. Do
Is
the
there a way
same
to
thing. And
is there a way to like share the entire thing that you're seeing over here? Like,
Harish, I would suggest you make a point. Probably later point in time we can play the videos.
yeah, absolutely.
Yeah, while you try. While you try.
So the
Yeah.
thing is, we had found a hippus that helped us a lot in this patient. So I wanted to show there we didn't have a critical care EEG, but then again you had see, we in Tamil there is a saying called Kallakanda Nayakana Nayakanda Kallakanda, meaning that when you have the stone you don't find the dog. When you have the dog you don't have the stone in hand. So that's that when you have very beautiful cases you don't get the EEG access very easily. And we have to rely entirely upon the clinical findings. Here, there are no obvious movements, but you are able to find those subtle movements which are able to pick it up, and that makes a huge difference. But here, I have another example of an entirely opposite thing where the patient, another baby, was treated continuously as a focal status epilepticus, like how Gagandeep sir had shown small twitching movements in the hand. I would like to show that. The baby was a 6-month-old baby treated by 6 different pediatricians or pediatric neurologist, on 6 anti-epileptics, drowsy, on O2 support, and then we had done an EEG, and then to show that that was not a seizure. So this is this kind of setting that I face over here. So to prove that this is a seizure, this is not a seizure, and then we stopped all the anti-seizure medications, and then we were able to find out that that was a kind of a movement disorder. So some genetic abnormality was there, and then later on, that's how we face as in practicality, what I do is we have a portable small EEG system, but I don't shift the costly equipments. There's a much cheaper one which we have as a backup that we send along with a technician to another hospital, and then we do a video EEG setup over there with the ordinary CCTV camera with a video capture box, and then we connect it to a laptop, and then we stream it via any desk or something, and I can watch it directly from anywhere I'm sitting. So that helps rule out all the artifacts also. I would like to show the setup, but I'm not able to show it. So the thing is, there EV score, where if you have birds, I ask them to ship the patient to us, and then we do a long-term monitoring, and then we will able to see if I have a lateralized periodic discharges or a hertz more than 2.5 hertz, I ask them. So a score of 1, I don't see it. It looks like more like it appears like we want the patient to be shifted to our center. So in a private setup, they are very, very how do I say, possessive about their patients. They don't want to shift unless they are unless they really want the best for the patient. So what we try to do is we try to help them as much as we can, and this is what we do in a private setup. What I would say is I'm in a tier 2 city, which I think most of the neurologists would be, uh, apart from those who in the tier 1 cities. So that's my thing about it.
Absolutely. Dr. Harish, I think you literally played out my own role as a pediatric neurologist here. The exact status quo that I face on an everyday basis. And the frustration of a neurologist when recently I got a Natus machine with a portable video EEG. I was so high and I thought, okay, that is it, we are going. And there was a kid with autoimmune encephalitis. And everybody forgot that we have a new Natus machine with a portable video EEG, and it was captured. The electroclinical event happened and without a video. And to training the paramedical staff, the neurotechnician, it is not easy. But yes, we are trying our best. And the very fact that we got a Natus machine itself, I think at this point, it's a nice thing. So anyway, moving on to Dr. Niharika. Dr. Niharika is an all-in-all institute person, anybody's dream career ladder that she's taking, the path that she's taking, PGI and IMHANS and now at Cleveland. Dr. Niharika, how do things work in your place, and what is it that you find that you could do in Cleveland Clinic, and what is it like at your setting right now? So can you share with us?
Yes, it's a very similar setting as what Prabjot described, like there is no resource limitation in that matter. So Cleveland Clinic Epilepsy main campus has multiple ICUs in it, and there are certain regional hospitals where they don't have a dedicated epilepsy staff in most centers. So when we read continuous EEG, we read both for the main campus multiple ICUs and also for the regional hospitals. On the adult side, at least like on a daily basis, there'll be 40 to 50 continuous ICU EEGs that are continuously going on. And at least three to four of them will be on having continuous status or some sort of no clinical sign seizures, which need like very frequent monitoring. But to maintain that, they have a lot of staff. They have around 5 to 6 technicians who are reading EEG continuously and marking it. And whenever there is an artifact in the ICU, they immediately go to the ICU and check it and then correct it. And there are fellows all the time reading the EEGs, and then there is 1 or 2 attending staff every 12 hours. That's the reason I think they're able to maintain that number. And when it comes to indications wise, as Dr. Gagandeep sir already mentioned, like if we take priority wise, if I have to prioritize, the first comes the convulsive status, which becomes non-convulsive, and then we monitor the throughout the management of the status. And the next is unexplained altered sensorium. But here, most of the time, all the patients with acute neurological conditions like strokes, IC bleeds, and traumatic brain injuries, SAH, whoever are in altered sensorium will have continuous EEG monitoring. Even if they don't have a seizure, they'll be on continuous EEG and will be reading it for 4 to 5 days. When I think, how do I apply in Indian scenario, I don't think I will be doing for all of them in reality. But sometimes I was surprised. Like 2 weeks back, there was a patient who had a posterior circulation stroke with a left PCA. In fact, he was a bit drowsy. And when we were doing continuous EEG monitoring, he was having EEG seizures like almost 15 to 20 per day. And though we were not giving him IV anesthetics or other things, we were giving medication to treat those seizures. So I was thinking, like, if in my previous scenario when I was in India, I wouldn't have done CEG on him. So I get that the resources are, and the number of technicians and how many fellows and attendings are there at a point are the main determinants of how to manage it. But as I said, like if we have to prioritize, the initial indications will be for NCSC and those with unexplained altered sensorium, later all the other causes. One more thing I wanted to highlight is when we start CEG, we don't directly start it. We do a portable EEG where we record it for 20 to 30 minutes and see what goes on in that immediately. We read the portable EEG and then we'll decide whether the patient requires a CEG. But in practice, almost everyone who gets a portable EEG ends up getting a CEG, again, mainly because of the resources, but we can even take a call based on
that triaging is very useful, isn't it? So, you patiently listened through what everybody had to say. And then what is your take on all of us working in different workplace scenarios? Do you think we can take critical care EEG to a different level or to the next level? What do you see in the near future?
So no, I completely understand the variations and some of the limitations or barriers, right? And it's not that we don't face those barriers, We started off many years ago with a single portable EEG, but now I think we have, I've lost count, we have 4 or 5 or 6 EEGs in the ICU. I completely understand the limitations in terms of technicians. We are slightly in a better situation because I work in a private hospital, a private medical college. So it is easy to get technicians to do what you want them to do, as opposed to the government setup where there are so many structural or bureaucratic barriers. It also involves a lot of time. And we don't have 6 epileptologists like Ajay said, but the residents really pitch in, and therefore I think the greatest thing that, or the best thing that we can do is to train both the residents and the technicians, right? Just like we train them. You see, at when I first joined my medical college, I thought, okay, we should have a EMG machine, right? Then the question at that time, as residents, when we were residents, we used to do nerve conduction studies. Right? We used to do, now, for all practical purposes, in all institutes across, this is what I've seen is nerve conduction is done by technicians, and they do it pretty well, and they understand all those things. But we used to spend a lot of time doing nerve conduction studies, right? So I think the important thing is to train delegates, train the residents in interpreting this, and that is what I really spend time. I think. I mean, it is not physically possible to see all the EEGs, right? We have a dedicated staff nurse who is very good, who can recognize all patterns. And then when the new batch of residents joins in, so they have to learn all these patterns and understand what is burst suppression and how to interpret, LPDs and things like that. But they all do a great job, and I'm extremely, extremely thankful to all the residents and the technicians, because never have uh, one of them ever complained, at least not to me, behind them at whatever, but they've never complained, right? So I'm extremely grateful to them. Mm.
So, Prabjot, yes, you want to say something?
Yeah, I thought I can probably just add to my experience in being a private practice in a hospital, which is a very well functioning hospital, where we have access to good technicians and we have access to CEG. So even in that setting, I think the times when we did a CEG was only for status epilepticus, because the luxury to do CEG for kids who have encephalopathy and not having seizures is not there, because it's just too expensive. You cannot do that. And even when, let's say, I do have a child in status, carrying on with the continuous EEG beyond a couple of
Right.
days becomes very expensive. So even for status, you sometimes have to take a call. You know that the child is having status, but you would still take a call between doing continuous EEG versus maybe doing 1 hour in the morning and 1 hour in the afternoon. And then you don't have residents or anybody to read them, so it is all on you. So you have to manage your OPD work and this CEG reading as well. So those are the challenges which are there when you're working as a consultant, as an independent consultant in a private setting where you have the resources, but you don't have all the other manpower to kind of, build up your CG reading and all that things. So yeah, just that.
I totally agree. That's my like at this point.
Yeah.
What Gagan sir said, yes, yes.
Sorry. No, no, we also don't do, I mean, we are not like the Cleveland Clinic, we'll do EEGs in all these, at the most we will do a portable EEG. Status is something that we will always try to hook the patient onto the EEG. But that's about that we do. We don't all strokes or anything. We're trying to build up a protocol for a project on post-stroke seizures, and but that is all experimental work, right? But We are basically focused on status. Yes.
So I think that was really good. The fact that you said when you train a resident, you pique an interest in him and then or her, and then they take it forward. And as you said, things have evolved beyond doing NCVs and EMGs yourself to this level. I think subsequently, if we show interest and a keenness to take this forward, I think this is doable in the near future, and there will be more and more people taking up neurotechnology. And it's not very far that what Niharika was saying that, how will she be able to do it back in her setting? Maybe those days are not too far if we just put together and, put our minds to that. So, do we have time for a rapid fire, or what do you think, Saraswati?
I think we
Of
should do
some
that.
clinical, you feel that? Sir, is it okay? A rapid fire of clinical questions, practical clinical questions.
Sure.
Okay, sir. So, and sir, please
Firing line.
comment.
Who is on the firing line?
The panelists, and you can comment and make your remarks as in when you deem pertinent. You can remark on this. Yes. So Ajay, how
Jyotsna,
often do you do? Yes, yes,
sorry for
Saraswati,
interruption.
not at all.
I think Murthy sir has raised hand. Can you just JMK Murthy sir?
Sorry,
I
I
see
didn't see
sir
that.
here. Yeah.
Okay, I didn't see that. Sorry, sir. Sir, welcome to the session. Please let us know. Yes.
So just unmute yourself.
Uh, so, Dr. Murthy, I have to say, when I was a resident, I was sent to Nizam Institute by my consultants, and I spent 3 weeks with Professor Murthy, and he taught me all I know about electrophysiology, including EMG, and so that was, I think, 94, sir. Sir, that was 94. You remember I had come to Nizam, and he actually held my hand and, while putting in EMG electrodes and taught me how to. Uh, and at that time, he had a full-fledged intensive care unit just for neurology patients. It had a huge number of beds and a huge number of ventilators, and he used to do a lot of EEGs at that time too. I'm talking of 94. Sir, do you remember?
I remember. So are you able to hear me?
Yes.
Yes, sir.
What I suggest for those who are not having a good mission for continuous EEG monitoring, if you have a portable EEG, you do recording in a suspected case of non-convulsive seizure for 60 minutes. If you don't get any ictal discharges, which lasts more than 10 seconds. It's more than 10 seconds. That is the new definition of ILA. So then it is unlikely that the patient is in is unlikely to be in non-convulsive status. I repeat, you take your EEG machine or shift the patient to whatever EEG machine you have, record it for 60 minutes. If you don't get any ictal discharges, which last more than 10 seconds, it is unlikely a patient of non-convulsive seizure. That is one thing. That can be done very easily. Once you start treatment, once with this 60 minutes record shows some ictal discharges for more than 10 seconds, you start the treatment, and then at that time you record, and you know that most of them will be able to suppress the non-convulsive status by usually 3 to 6 hours, maximum 6 hours. If you are be aggressive and you have your own protocol, then this is the one best. And we wrote a paper on this in epilepsy. So this is the one system which can, or you will be able to help some patients with.
Yes, sir.
Thank
Yeah,
you.
but what sir is saying is basically, if you do 1 hour EEG, there is a 50% chance that you will record your seizures in the first 1 hour.
More than
Yeah. And so therefore,
50%.
that is going to tell you a whole wealth of, that's going to provide a whole wealth of information. 1 hour is enough to record more than 50% of the seizures.
80%.
Yes, sir. Thank you, sir. Thank you so much for the inputs. So now I think we will wind up the session with 4 take-home kind of points by asking panelists one question each. So Dr. Ajay, if you would want to triage, and which of these situations do you feel needs the most importantly the continuous EEG monitoring? Is it a patient with a new onset refractory status, or do you think a patient with a drug withdrawal status, or a compliant patient with epilepsy presenting with status? How do you choose which patient needs continuous EEG in your system?
Yeah. So the bottom line is that all these patients need an EEG at the least. As far as continuous EEG is concerned, as we've all spoken, the priority should be for new onset refractory seizures. So that is the situation where you have to act fast. The what we call as the T2 point is fast approaching, and then neuronal injury is going to happen. So you have to up titrate as soon as possible and go to the next step if anesthesia is not working. I mean, anti-epileptics are not working, go for anesthesia, achieve burst suppression as early as possible. So that is the setting where I would want to prioritize the continuous EEG.
Right. So thank you, Ajay. Moving on to Niharika. Niharika, 2 things for you. I think Prabhat can also comment on this. One is the IIC and the NCSC and the current terminology, if you can briefly touch upon within 30 seconds to 1 minute. And second thing, we have discussed that you are using AI for critical care EEG. Tell us about these 2 things briefly.
NCSE already we have discussed in detail. Like once the convulsive seizure stops, then we need a continuous EEG monitoring to understand actually whether the non-convulsive status is going on or not. We know the basic criteria for NCSE, like at least 20% of the record should show EEG seizures. But when it comes to IIC, I think like there is a lot of controversy regarding when to treat and when not to treat. At least the place where I'm training, like what we look for is these patterns where there is a more higher chance of seizures in the next 24 hours. Like whenever we see the LPDs, like or previously used to be called as FLET patterns, especially when the frequency is approaching 2 hertz or when they are very sharply contoured or there is a rhythmic delta associated with it. Those are the patterns where we will be more careful. For those patterns, we don't increase the anesthetic agent, but we will give more ASM doses to suppress them. The ones which we take very serious, almost like a NCSC, is the birds, where we treat them like a mini seizures and we increase the anesthetic agent. So I think it's very important to understand when not to overtreat to, like in sometimes when there is a brain injury in certain part of the brain, we do see continuous bloods, and if they're low frequency, we don't have to treat them very aggressively. So I think birds and LPDs or LPDs with some rhythmic delta activity, they come under priority compared to the other patterns like GPDs and other things. And whenever there is a clinical phenomena, we take it as clinical seizure and we treat it. We don't care about the EEG pattern. And another thing about circuits, we don't bother much about the circuits mainly because it's more state changes and we don't have to worry unless there is any other indication that helps us to treat it. I think I took longer time. I'm sorry.
Yeah, that's fine. That's fine. So the thing is, irrespective of whether you stick to the ACNS and use the word ictal interictal continuum, the important thing is to conceptually understand which are those discharges that you have to prioritize and treat. And I think that is the way to go. Right. A quick word about AI in critical care.
Okay, we use Persist here, AI software for quantitative EEG. We use it for every patient because we have it for all the patients. I feel personally that it's not needed, especially in resource limited settings. But if we have to read 30, 40 EEGs like in 2, 3 hour period, it helps in some particular scenarios. I most commonly like it for one, seizure number count. Like whenever we see a EEG seizure, it shows a particular flame-shaped pattern on the DSA graph. And sometimes if, for example, I increase the dose of ketamine, I want to see what happened in the next 2 hours, the seizure count reduced or increased. I can just count the DSA flame-shaped numbers and I can see like, okay, now it's 20 seizures. I don't have to go through the entire record or count every seizure. So it helps with the medication management. We don't have to go through the entire record. That is one thing I find it most useful. The second useful is the spike detector in the less serious patients, like who just have continuous slow encephalopathy. They don't have much seizures going on. There is a spike detection parameter in it, which detects some epileptiform spikes or things like that. So it helps us to understand whether we should really increase the ASM doses or not. Other than that, it's pretty sensitive. It detects seizures, but the problem is it detects arousals as seizures. So a lot of false positives. So we need to exactly know in that particular patient what is the seizure counterpart of the DSA, so we can monitor only that one. Otherwise, I don't think that it's necessary.
Right. So, Prabjot, a quick take on pediatric. You're a pediatrician, and I cannot not have a pediatric neuro question here. So, pediatric and neonatology and critical care EEG, relevant, not relevant, and what's in your views?
Oh, it's definitely very relevant. And like we just discussed, that status epilepticus is probably the main thing where we do it. And there are other indications like Dr. Ajay was mentioning stroke. We have stroke kids who are at high risk for seizures, or we have kids who are at high risk of seizures in situations where they are on muscle relaxants and stuff. So that helps. Neonatal EEG, I think it's probably not for a lot of interest to this group, but neonatal EEGs are something which are very fascinating, and I think you know it very well, Jyotsna. Because neonates can have a lot of electroclinical dissociation. You can have high-risk situations where you know they might be having just electrographic status and clinically you see nothing. And then there are also situations when they have all sorts of abnormal movements, especially when they have had HIE and other injuries, and they're all sometimes overtreated as seizures, and they're actually not seizures. So very, very relevant in both situations.
Right. Thank you so much. Especially the neonatal spectrum, I think no population like neonatal where critical care EEG is important. Right. To wind up now, Dr. Harish, at the end of this session, do you think treat the patient and not treat the EEG holds good holds steady in a critical care setting? We would want to have a punch take home here. And then how can hospitals with limited EEG availability, can you still do or optimize neurocritical care with EEG? What do you think? What is the message for our young neurologists?
I would say it is very. I'm going to give you a diplomatic answer. You always treat the patient, not just the EEG, but it depends on the clinical context. If it's not, or if it's a non-convulsive status epilepticus, you would definitely have to look at it because you have to prevent the neuronal loss. And yes, it is definitely possible to start a critical care in a resource poor setting. I guess you just have to find ways to make things happen. I think you can still do it, but we're trying to do something. But yeah, I think we can do it. We will be able to do it.
Yes, sir.
Yeah, treat the patient, but the EEG is also of the patient only, right?
Absolutely. So I think that clinical, yes, for diagnosis and treatment of epilepsy, yeah, we are putting a lot of money on the clinical aspect. But when it comes to neurocritical care, I think EEG really stands out as a very important neuromonitoring tool. With that, I think Saraswati was keen to take round 3, but I'm not sure. We have really exceeded the time.
It's
So,
rare that we
what do you-
find all the experts here, so I think you must take, and it's really a learning experience for me.
So we will leave it to sir.
With permission of
Gagandeep
sir. Yes.
So we had actually prepared a round 3 for this. Do you think that we can stretch, or do you think we will wind up?
Well, as long as it is a quick round, right? I'm sure.
Right. All right. So we'll make it a more rapid fire. So Ajay, burst suppression and treatment target. I think sir discussed this. So if you can briefly say, burst suppression, is it ideal?
Yeah. So burst suppression has been the target for a long time. We have been trying to, whenever for a patient with super refractory status epilepticus, the anesthesia, the depth of anesthesia, and how long we treat has been decided based on burst suppression. And ideally, a burst suppression of 9 seconds, 10 seconds is also what is taught. At least 50% of the record is what has been attempted. But recently, the evidence profile for this has been questioned. And most of the evidence is because it's mostly out of convention and case reports rather than proper evidence. And a paper came out in 2013 in Neurology from a Swiss center. They looked at, it was a retrospective study of about 9 years, and they found that patients who have achieved burst suppression and without burst suppression had almost the same outcomes. So whether it is a valid target is again questionable, and none of the recommendations nowadays mandate that burst suppression has to be achieved. It is more of people have started to think that controlling electrographic seizures is more important than burst suppression because burst suppression requires a higher depth of anesthesia. Yes.
Absolutely. So I cannot not mention Vinay sir here. He just says one thing, that we are excited about burst suppression and all the status going off. He says, how sure are you that you're going to reboot the system? So don't be too over enthusiastic about burst suppression. I think sir did mention that in his slide with that graded green to red. And what we are looking at is the happiness of burst suppression. That kind of a thought process doesn't exist anymore. So, Niharika and Prabhjot, I've already finished your aspect. I clubbed the round three questions for both of you. So, I'll directly go to Harish and wind this up. So, Harish, we need referrals. And when Ajay made this very pertinent point that, like stroke-ready hospitals, we probably need a status-ready hospital or a epilepsy emergency-ready hospital. How do you think we can increase the referral, or rather give this take home to a referral physician or a pediatrician that these kind of patients have to be managed at status ready hospitals? And how do you think this critical care we can make it, we can percolate it to every, as much as possible, at least in the tier 2 cities of India? So what is your suggestion? Is it better training, or how do you think we can do this?
So yeah,
Because
better
most of us sit
training.
in centers like, yeah,
Absolutely.
yeah.
You have to go meet those kind of patients, those kind of areas where you know, by the time you are in a city, you'll get so many calls from one particular hospital which tends to attend to all these kind of difficult patients. The first step is to reach out to them and to tell them the importance, and then reach out to them and then conduct more CMEs or something, and then to discuss and tell them the importance of the neuronal loss that the patients might incur if they don't get the timely treatment. And I would suggest you spread awareness as much as you can, like how we are doing right now. You try to involve more number of people. In the research support setting, you're just running behind patients. You don't have much time to just sit and then talk to people. But then again, when you have good cases, you try to share them, try to tell the positive things about them, and then probably create a system, create a guideline where these are the strict criteria. If you have a continuous, if the patient is not awakening, if the patient has had seizures and new onset seizures and which is refractory, and then you have these kind of simple words that they might even understand. So anything that is unexplained loss of consciousness after a stroke or something, and then you inform them, you have to inform us, and then probably we can come back and then give you a better opinion, and then that's when we can see. Here the more ideal situation would be to tell them what is at stake rather than telling them to refer. You just have to inform them what is at stake and
Absolutely.
what.
And nothing like demonstrating with a good case, a case with a good outcome. You put a video and then you show, like sir showed with the Alzheimer's patient. It's like when you see that, nobody can not refer, right?
Yeah,
So,
so
yeah. Thank you so much, Dr. Harish. I think Gagandeep sir wants to make a comment. He has raised his hand.
A very quick one, right? A very good target, and which can be done by everyone in this forum, is targeting your epilepsy patients, right? People with epilepsy who come to your clinic. How often do we discuss status with them? We don't discuss. There is every person with epilepsy has the potential of going into status, right? If he misses out on his medicines, right? So this is some, and there are some who are at extremely great propensity Ds and all those kind of things, right? So it's very important to, I think it's extremely important to discuss and make a plan with the patient. So this is how important it is to time seizures. Who time seizures? No one time seizures, right? If you can, please time seizures. If you can, please video the seizures. But if the seizure lasts for more than a minute, this is what you need to do. This is where you need to go. And creating that awareness amongst patients about what is status epilepticus. Do our patients with epilepsy know what is status epilepticus? I think as clinicians, that is something that we can easily do, right?
Absolutely. So, right. So here we come to the end of this session. I cannot thank enough Dr. Gagandeep sir for giving us this time, sitting through the session and answering all our questions. I also thank our panelists, Dr. Ajay, Dr. Harish, Dr. Niharika, Dr. Prabjot for sharing your excellent thought process and how you've been doing it. And overall, the outlook that I think any young neurologist sitting through the session would take is that yes, we have learned and we can do, and things are going to evolve. Critical care EEG, we are a heterogeneous setting in India, but we can still call ourselves a resourceful setting, because there are certain settings where we can do the we can offer the current standard of care to the patients. And with that positive note, we wind up this session. Any further remarks by you, sir? Then we will close it.
It's really enjoyed, right? Thank you, Jyotsna. Thank you, everyone.
Thank you,
Thank
sir.
you
Thank
so
you
much,
so
sir.
much. Thank you, sir.
Saraswati?
Yeah, thank you so much to all our speakers, Gagandeep Singh sir, for this enriching discussion today. And I hope this discussion will further stimulate more research, learning, collaborations, etc. And as Jyotsna rightly termed, I think the catching word today was status ready hospitals, and maybe have many more such. So thank you so much. Thank you for spending a Sunday in this YNF forum. Thank you.
Thank
Thank
you.
you, Dr. Jyotsna,
Thank
for
you.
having us.
Thank you.
Thank you.
Thank you, Harish. Thank you, Ajay, Prabjot, Niharika.
Bye.
Bye. Bye.